Now we've come to the end of our presentation, and I've taken a few thoughts and I'd like to review them as useful conclusions and food for thought. The PIP joint is a tightly constructed hinged joint that has very little accessory movement available to it. It enjoys a strong extrinsic flexion power, but has a relatively weak intrinsic extension power, and it is very prone to flexion contractures because of this imbalance. PIP joint extension is a complex combination of tension throughout the fibers of the dorsal apparatus as they work together to create full interphalangeal joint extension, not just PIP extension. The extensor digitorum communis contributes some to PIP joint extension, but it does not do that when the MP joint is hyperextended. If you block the MP joint, then the extensor digitorum communis contributes strongly to full interphalangeal joint extension. It's important to identify the cause of the limitation of PIP joint motion and to differentiate between joint tightness, interosseous muscle tightness, extrinsic flexor or extensor tightness, or adherence of extensor or flexors somewhere within the system. Keep in mind that with many injuries, there is more than one factor present, and an experienced evaluator can determine how many factors are at play and which is the most dominant. PIP joint extension is often our clinical challenge. Traditionally, we provide an orthosis for passive extension, or we use serocasting, but either of those approaches does provide some immobilization, provides no active glide, and with intermittent removal, there is a return to a pathological pattern of movement. However, in my opinion, these traditional approaches are very useful at the beginning following an injury to reduce the edema and the resistance to active extension of the PIP joint, and they may also be useful at the end to maintain weaker extension at night when we do hold those joints in a flexed posture. Active redirection is a simple approach. It blocks normal joints, directing muscle force to stiffer joints until they are mobilized and the patient can revert to a normal balanced active pattern. Active redirection accomplishes differential tissue glide actively while avoiding passive motion, which affects cortical repatterning and provides stimulation to the lymphatic system to reduce digital edema. The use of active redirection is appropriate whenever increased motion is needed at one joint, and a non-removable Sims cast should be used when prolonged stiffness of multiple joints is present, and also when nothing else is working. It can be useful. If you choose to use a Sims casting technique, I strongly urge you to read the reference material. PIP joint active redirection is easy to use for increased PIP joint extension by blocking MP joint extension to drive the power into the dorsal apparatus, or following a boutonniere to block the DIP joint inflection to increase participation of the lateral band in PIP joint extension. Likewise, active redirection can be used for increased PIP joint flexion by blocking MP joint in extension to eliminate the power of the interosseous to flex the MP joint before the PIP joint. Constructing an active redirection orthosis should be done for each patient because the balance of motion is different, and the orthosis needs to be unique to the patient's balance of motion, and this may require some trial and error to make an appropriate and comfortable orthosis that can be worn full time.